I think it's about yeah.
Yeah, just a few seconds. I'm reminding people in groups here. Okay, let's start, Joseph. I hope others will join us as we proceed.
Sure. Good evening, everyone. Welcome again. It's another Sunday. We're so excited. We missed David discussing a case, and today we're going to learn a lot from him. It's a case that I saw, and it drove me crazy on the first day, but later turned out it was just a simple case. So this was a 20-year-old female who presented with a painful right arm swelling for 3 months. I think we can stop here and listen to David.
Yeah, so I think just to in order to keep our new tradition of having a co-discussant, maybe let me ask if there are any volunteers, anyone who volunteers to co-discuss with me, so we can tackle this together, because Joseph has already given his disclaimer that initially had a hard time with the case. So I think it will be the same for us. So anyone who is willing to co-discuss with me. So far, we've had three discussants: Michael, Seba, and then Roland. So anyone else apart from the two usual people, David and Joseph. So anyone else, it can be the three or any other person. So if you want to co-discuss, you can just raise up your hand. You can use the hand icon in order to raise your hand, and then we can tackle this together. Okay, I see there are no volunteers. Okay, so okay, I see one hand here. Yes, Elias, that's very good. Okay, let's do this together. So can you just I think it will be good for people to just know you as much information as you like to volunteer. So maybe what are your exact names? What is your, whether you're a medical student now, a registrar, a resident, or anything, where you are currently stationed. If you can share that, unmute yourself and say hi to the group.
Okay, so I would say good evening to everyone because here it is evening already. So my name is Elias Welema. I'm a medical student here at Tanzania. I'm currently enrolled in a university called Catholic University of Race and Earth Science, Uganda, located at Mwanza region. And it's my first time to be in this webinar, so I hope what I'll be sharing here today will be valuable to others and will help us learn a lot from this case. So I'm looking forward for it. Thank you.
Well, that's very impressive. So, in which year are you currently in?
Oh, okay. So I'm currently a first year medical student, and for those who don't know the curriculum here at Tanzania, we usually take 5 years of training to in order to graduate as a medical personnel. So I'm currently on my fourth year and 1 year to go in order to graduate.
That's very impressive. So I'll tell you, we've never had a fourth year medical student discuss a case in the group. So you're a star, my friend. I think Joseph is also very impressed with that
Yeah.
as much as is everyone else. Actually, yeah, most of us share the same share the same curriculum as you, because majority, I think, if not 100% of the people have trained in Tanzania. So we are very eager to learn from you today. So if you don't mind, can you start sharing your thoughts on the case? What are your thoughts when you hear that we have a 20 years old female with a painful right arm swelling for about 3 months? What comes to your mind?
Okay. So for getting the age and the sex of the female with painful right arm swelling for 3 months. So basically, this is a gradual onset, so it means it is a chronic issue. And this is a chronic issue, it might be dealing with a benign issue or other malignancy issues. So for this history taking, this is the symptoms for I would think of maybe a benign tumor, maybe. I would think of that. Also for other thing I would think of maybe this condition which leads to swelling elephantiasis. So that is the differential diagnosis, because basically they also present with that condition in upper limbs. So another thing maybe I will think of I think I would go with those two first. Let me go again with the as the story goes on. I will also come with other differential diagnosis, but for currently I think I will go with those two.
Oh, that's very impressive. I'll tell you. I have my notebook here and I'm already taking notes. So, and I hope everyone else is doing the same. Actually, that's a very good start, and for me personally, very impressive for a fourth year medical student. So, because you started with very pertinent issues. So, number one, with the time course that we are dealing with something for 3 months. So basically, we're in the territory of something chronic rather than acute. And then thinking about the differentials of swelling. So, for example, you talked about a possibility of something like a neoplasm, for example, a benign tumor, and then also thinking about lymphatic obstruction. So that's already a lot of progress made, and you actually helped organize my mind in a huge way. So uh, I'll also say that with right arm swelling, we are talking of arm swelling for 3 months. These are not arm swelling is not personally is not a complaint that I come across many times, and especially when we include a duration of 3 months, I think it complicates the matter more. But then just like you started approaching this issue, I think we have a number of possibilities. And when we get the HPA, I think it will help us clarify some issues more. But then, just as you talked about it, we can choose a number of ways to approach it. For example, if we think anatomically, we are talking about the arm. Of course, we are interested to know what exact part of the arm that is swollen, because we could be talking about the upper arm, the forearm, or the upper limb in general. But then, if we approach it anatomically, of course, it could be something in the skin. I mean, starting from outside going in, you could have something on the skin. You could have something in the subcutaneous tissue and fascia. So, for example, for subcutaneous tissue, if we find out that we are dealing with the localized swelling, then we could talk of something like a lipoma, for example. So the skin, subcutaneous tissue, fascia, and then we also have bones. So if someone has an osteosarcoma, for example, it may also present with swelling of the arm. So it's something that arises from the bone, but outside you will see a swelling. But also, as you rightfully said, we also have the vascular territory there. We have arteries, we have veins, but we also have lymphatics. So she's pretty young. But of course, if you see someone, for example, with advanced breast cancer involving the lymph nodes, or someone who has treatment for breast cancer and therefore there is lymph node dissection, they might end up with lymphedema as a result of a removal of the lymph nodes and therefore compromise of the lymphatics. So lymphedema is something else. So I think we have a number of possibilities, but something that adds another layer of complexity is the pain. We are dealing with something that is chronic, but then associated with pain. So if there is vascular compromise, you can so for example, we know that even things like when there is for example, venous obstruction can lead to a buildup in pressure, leading to swelling, leading to pain. So I think we have a number of things to deal with. So Joseph, can you give us the HPA in order for us to see if we can make any progress?
Yeah, that's a good start, especially from a fourth year medical student who is going to teach us. I'm so impressed, by the way. And so let's see the HPI. Story is like this. So 3 months ago, this patient woke up in the morning with a painful swelling of the right hand. She reports that she was completely normal the night before. It was associated with involuntary tremor and hand weakness. She described the pain as extreme and burning in nature, but there was no numbness, fever, or change in color of the hand. Over time, the pain and swelling ascended to upper parts of the limb, but the rest of the three limbs were normal, and she didn't have any fascial weakness, trauma, or seizure. Just that.
Okay, so that's what we have. Elias, what are your thoughts based on the HPI? So we have some more information. Any thoughts?
You're muted there. Okay.
No. I'm still digesting the HPI. Well, for me, I think I still go with those two because I think I go with those two because I still not get the picture why because there's no sign of infection as there is no fever. So there was no sign of infection, and also there is no sign of any B symptoms which may suggest of a malignancy. Also, I think I might be dealing only with benign issue, as I said, maybe a tumor, maybe it has broken the lymphatic vessels. That's why it has continued leading to a swelling, or maybe it is infestation of elephantiasis. So I'll see go with these two. Maybe I will change later for if there is anything which I pick up on the history. But for for malignant, it's not likely as for breast cancer because the age, it is very rare, maybe because it's a case, but for malignancy, maybe there's no even history of a surgery, so it's likely not, it's most likely not to be the one. So I'll say go with those two. Maybe a tumor is enlarging, or it is elephantiasis. And I will come up with another one if I get something on the way.
Okay, thank you very much, Elias. So here's what we have. I'll just add a few things. So we see that the evolution of the symptom, at least initially, the evolution of the symptoms was, so you see the patient went to bed completely normal, and then the next morning she wakes up with painful swelling of the right hand. And then over time, and then of course we see some other symptoms like tremor, an involuntary tremor, and then and the hand also had weakness. And then the pain is also extreme and burning, but otherwise no numbness, no fever, or changes in color. And over time, the pain and swelling ascends to involve the upper parts of the limb. So what am I thinking about? So generally, when I see something like this, so just like I said before, I mean, apart from, I mean, unlike other complaints, like for example, when you have, when you hear about cough or difficulty in breathing, or someone vomits blood, we have very specific schema for those. But then for something like an upper limb swelling, then I think those are not complaints that we come across very often. But so with a history like this, I mean, based on extrapolating from other organ systems and from other complaints that we come across commonly, something that comes about this quickly, but then also involves, I mean, it deserves giving a thought, or at least assumptions, that there is some involvement of the vascular system. So if someone goes to bed just fine with no swelling, and they wake up the next morning and there is swelling, so I will entertain a possibility that there is some vascular issue going on. So for example, venous obstruction, for example, and this venous obstruction can lead to building up of pressure slowly, and as pressure builds, there will be swelling, and there will be pain. I'm not very much entertaining the possibility of arterial obstruction, for example, because if there is arterial obstruction, commonly what we see, we would expect to see gangrene, but Joseph is telling us that there is no color change. And with arterial involvement, if someone has an arterial thrombosis, for example, and there is a complete cutting of supply to a certain part, then we would expect gangrene. In no time, this limb will turn dark. So if we are talking of something vascular, then something venous is a possibility. So lymphatic obstruction, of course, lymphatic obstruction can cause swelling, but commonly what we see, is with lymphatic obstruction. Of course, we do not expect a pain, at least at the beginning, although as the swelling becomes severe, then there could be pain. Now, another reason that makes me think that we are dealing with something vascular that leads to building up of pressure is because of the neurological symptoms that we see. Because if it was something purely neurological, then we would expect the tremors, for example, the weakness, and then that's it. But otherwise, we see that there are tremors, and there is weakness, and then there is associated pain. So positive sensory symptoms, that is pain, rather than negative symptoms like complete loss of sensation. So this patient is having pain and burning, which is a positive sensory symptom. That could fit well with the hypothesis of a vascular issue, because as pressure builds up, it can lead to so like when you talk about, I think we've heard about compartment syndrome. So I do not see all features of compartment syndrome, but I think that is one thing that can be entertained. But then because this is building up and then going up, that is what makes me keep it low on the list. Because for compartment syndrome, we already have one thing that is pain. And then because we have the 6 P's, I believe the 6 P's. So you have pain, you have pallor. Joseph is telling us that there is no change in color. And then we have paresthesias. Joseph is telling us that there is pain and burning, which could be equivalents. But then pulselessness, that is something that can be picked on physical examination. So but now if we entertain the possibility that we are dealing with compartment syndrome, what exactly is causing it? So compartment syndrome, of course, can explain the swelling, the pain, and all the other things that I've talked about. But at this point in time, I think high on the list is something vascular. And out of the vascular, I think venous is more likely than arterial, because there is no associated gangrene in this patient, at least as far as the history goes. So venous more likely than arterial. And another thing is lymphatic obstruction. Just like Elias said, I think we also need to keep that close. But then, what if it's none of the things that we talked about? Cellulitis, for example, can explain swelling and pain. But especially if a patient has a fair skin color, we would expect a color change. But I think we need to entertain that possibility. But then with cellulitis, especially, that has been ascending and it's present for 3 months, that is the hiccup that we have. That we are dealing with cellulitis for 3 months. That is the hiccup. But if we are to think broadly, I think cellulitis would be another possibility. I mean, outside the vascular territory that we've been talked about. With regards to fasciitis, for example, you can have fasciitis leading to compartment syndrome. But then with fasciitis and the compartment syndrome, then for 3 months, we would have expected to see some gangrene. So we discussed the case sometimes last year when we were just starting AfroDX with Joseph, and it turned out to be necrotizing fasciitis, but that was associated with visible color change. So I think if we are dealing with fasciitis leading to compartment syndrome, we would expect to see some changes that were visible outside. So I think those are the possibilities. Something vascular high on the list, but we should also remember to think about the other things that we talked about anatomically, whether involving the skin, subcutaneous tissue, fascia, muscle, something to do with the muscle. So something to do with the nerves. If the problem was primarily in the nerves are too tiny to lead to a swelling that is observable on the outside. So I do not think this is a primary issue with the nerves, but the pain and the neurological symptoms that we see, I take them more as complications rather than the cause. So I think that is where we are to this point. Of course, we'll need some issues to clarify, especially with the past medical history. I saw Michael asking some questions here, like the occupation of the patient, because yes, so with some occupations, you also have you can have compartment syndrome, which comes with as a result of some occupations. Of course, carpal tunnel syndrome is not something that maybe fits very well with this patient, and of course that could be because of my limitation in knowledge. But I think just like Michael asked, it's also important to know about the occupation, though Joseph has already answered that, and I believe we'll get more information, especially we are looking forward to the review of systems, but also the past medical history. And especially on examination, we'll need to clarify this. We'll need to see this patient has any lymph nodes, especially in the axillary area. That's very important. So that's where we are, Joseph. Can we proceed, and we'll clarify our thoughts as we go?
Yeah, that's a very good discussion about the HPI. So let's see the rest of the history, which is there's nothing much. The review of other system is unremarkable. Past medical history, non-significant, nothing showing off. And the meds, she's not on any meds, including COC. She's not on a COC. Someone asked about the COC. From a social history, she's a high school student. Her first degree relatives are healthy. And yeah, that's it.
Okay, so I think there's nothing much to be discussed here, but I'll just ask Elias if there were some things that you were expecting that would help you make some progress, whether this additional information has been helpful in making progress or not. Is there anything on your side with regards to the other components of history that have been presented?
Well, at the history presented itself, let's say, seems that there's no anything that can help us in formulation diagnosis, maybe as we go further. So, for example, something which I really needed to hear from the history is, for example, familial history. Maybe if this condition has ever presented to a family member, maybe can help us to make the diagnosis. Maybe it is something which is inherited. Also, a sort of in past medical history or any surgical history, which he or she had. So as the history presented, it means that she has a clear history with no with nothing which can help us make a diagnosis. So that is also something which is challenging. Also, for example, I expected also in medication, maybe because there are also if she's in any meds could help us in making diagnosis. Maybe this medication has a side effect which present to this situation. So basically, I have nothing up to now in regarding this, which will make me to change my diagnosis or have another diagnosis. But something which is challenging up to now is the neurological symptoms which presented with tremors, and so this is something which makes me alert something. Maybe there is something which I forgot. So let's see what is on the other side. Maybe in a physical examination, maybe we shall pick up something. Thank you.
Well, so just before I proceed, let me just say you'll make a very good clinician. Your thinking is very advanced beyond your level, because the things that you're considering, I think some of us were struggling when we were at your level. So just keep up. You'll make a very good clinician. So
Thank you.
very precisely said. So we're very much interested with so an issue with medications, for example, as you mentioned. And I see people, for example, Ali raised an issue of whether the patient was any combined oral contraceptives, because we are because part of our thoughts, whether there's anything in the vascular territory. So, for example, vascular thrombosis, which are combined oral contraceptives, are known to have some prothrombotic risk. So that is the thought. And yes, we do have medications, for example, that can lead to fluid retention and lead to swelling. They may not explain everything or every part of the patient's presentation, but so things like NSAIDs are known to cause some sort of fluid retention, although may be not upper limb swelling. Calcium channel blockers like amlodipine can cause edema, but we see that more commonly in the lower limbs, and that is in some patients. So this patient is not on any medications, and then, as you very correctly said, a history of surgery. Because yes, if this patient had some surgery, especially involving the upper limb, for example, or any nearby structures leading to, for example, any compromise in the lymphatics, then the swelling would be explained by that. We already talked about lymph node dissection earlier on. So those would be explained by the surgical history. This patient doesn't have any. And then no similar history in first degree relatives. Yes, so there are some things like, for example, if we talk about thrombosis, yes, it's not just combined oral contraceptives. Someone can have thrombosis in the veins, in the arteries as a result of antiphospholipid syndrome, for example. So of course, we cannot throw that away, but then the first question would be this history of swelling of the right upper limb, which started with the hand and then progressed. Do we think that it's a clot that is in the veins, for example, in the arteries, which is less likely? Or of course, with the lymphatics, we are not talking about a blood clot specifically, but then lymphatic obstruction, for example, as a result of lymphadenopathy or any other thing. So yes, you have things like antiphospholipid syndrome, but then we do not see anything else in the patient's presentation that could point us in that direction. So yes, the past medical history, the review of systems, I think it's helping us rule out a number of things, as well as the family social history. So she's a student, no occupational exposure, a question that was raised by Michael, and then she's not on any medications, including combined oral contraceptives, and then a few other medications that I mentioned, which can cause fluid retention. So what is going on with the patient? I think that's a question that remains. So up to this point, I think we haven't made much progress. And yes, Elias, I share your concerns that there are some other things that we cannot explain. So, for example, the tremor with this limb, I would say the pain can be explained. If we are talking of vascular obstruction, pressure is building up. Pain can be a direct consequence of that. But what about the tremors? I think that is a question that we have, but we are lucky that Joseph attended the case, learned from it, and therefore is going to teach us later. So I hope physical examination is going to help us make some progress. So Joseph, back to you.
Sure. Yeah. Dr. Elias, medical student, very nice. Your confidence also is superb. I like that. So here's the exam. This patient, when I saw her, she was alert and oriented. She was in severe pain and she was febrile. She was not pale. She didn't have lymphadenopathy even in the limb that was swollen. The axilla of that limb didn't have lymphadenopathy. There was no lower limb edema. The vital signs were unremarkable. Blood pressure present, normal. Respiratory rate, temperature, saturation were all normal. Local exam of the limb. So the limb was swollen. It was a spastic hand, which means that it was a clenched fist with a thumb flexed in the palm. It was not warmer compared to the left upper limb. It was tender to both slight touch, which was not a normal tenderness, which qualifies to be called allodynia, like hypersensitive to touch. And also, if you compress it deeper, it was so tender. The tenderness started from the hand to the shoulder, but also involved the chest muscles in proximity to the shoulder. The power was 1 out of 5 in all muscle groups of the right upper limb. We're not sure if all the weakness was because of pain or if it was because of neurological weakness. But based on the history, we thought it is both. But there was no loss of sensation in that limb. But the rest of the exam, it was completely normal. Yeah.
Okay, Elias, here is the physical exam. Any thoughts?
Well, thank you again. So, from what I've come up with, the first 10 which I took is not to armor. So, from what I've studied is if in local examination of a certain limb, if you find it is warmer, it means there is a continual information or is a sign of is a cardinal sign of inflammation. So not warmer, it means there is no inflammation taking place. Also, there is other thing which makes me think more. Not warmer means is poor perfused. Okay, so I'll use this knowledge in, for example, in heart failures. In heart failure patient, they present with cold extremities, and what we say and what we rely on saying that in interpreting this sign is poor perfusion. So if the hand is not warmer, maybe there is no inflammation, or also there is poor perfusion. But I would expect to say if it's cold, but I raise an alert not warmer and it is swelling. Maybe there is poor perfusion. I would say the area there is the vesicular involvement. So another thing is on neurovascular examination. No, neurological. So the limb has lost power. That means there is neurological involvement. So with 1 out of 5 means there is a paralysis of the limb. So paralysis of the limb lays another thing, because from anatomy, the lower limb is supplied by brachial plexus, which give us its root from. Sorry, I forgot the roots, but it involves the cervical plexus and the cervical plexus and the thoracic root. So the nerves which supply the limbs are radial and ulnar and median, and they supply the muscles. So paralysis of the muscle, loss of the power, means there is a total involvement of maybe a plexus, because I would expect maybe there was some movement, because there are various groups in the muscles which are supplied by various roots. So I would expect maybe some movement, maybe pronation. The hand was, maybe the patient was not able to pronate, or maybe the patient was not able to maybe to extend or to abduct. So means 1 out of 5 means paralysis. So maybe there is a total involvement of the roots. And another thing is there was no loss of sensation. So another question is, why no loss of sensation but there is loss of motor activity? So I was thinking maybe there is, I'm changing now. Maybe there is involvement of the upper extremity. Maybe where the origin of the vessels. As you say there is maybe there is compression of the vessels such as vein, or maybe there is a compression of the plexus. So I would suggest I would go with that maybe for my level, and I would change from elephantiasis. I will drop elephantiasis I drop elephantiasis to be. So sorry, elephantiasis was my differential diagnosis. My first diagnosis was tumor. So I would go see with a tumor. Maybe there's a tumor involving the upper extremities where the plexus are passing, or the roots, or the divisions. So I would go see that, and maybe there's something compressing. That's why the patient started destroying the distal up to the proximal. So I'll still go with the tumor, but also maybe there's something compressing as suggested the tumor. So for my level, I would say only that. Maybe back to you, George.
Well, once again, I mean, I'm speechless. I mean, with the way you integrate the anatomy, the physiology, and everything, that's very impressive. So, and of course, you are teaching us. You are teaching us a lot. So, for example, the way you thought about the weakness and then related it to the brachial plexus, that's unbelievable. So of course this is a tough case. This is a tough case, but I should say we might not get the diagnosis right, but the learning that is taking place today is one of a kind. So just like you said, yes, Joseph told us that this right upper limb is not warmer than the rest. So just like you correctly said, temperature, we say it's so we mentioned there's so the temperature, we use the term calor. So that I believe those are Latin or Greek. So when it is warmer, of course, that's one of the cardinal manifestations of inflammation. So if we talk of something like cellulitis, commonly we expect the limb to be warmer as compared to the contralateral limb, for example. So, and yes, so when you see a limb swelling, of course, some of the things that should very commonly be thought about, or that we encounter commonly. For example, if we are dealing with the lower limb, of course, our top differentials would be we are dealing with cellulitis or we are dealing with DVT. So we can extrapolate the same here, but then the question would be cellulitis for 3 months. Of course, we have not seen it all. It could still be a possibility, but the fact that we do not see the limb being warmer than the rest, that makes it less likely. And of course, if we had cellulitis of the limb for 3 months, then most likely that limb would have Joseph, can you help mute oh, Joseph. Sambelia, can you mute your speaker? Joseph, you can help mute your speaker. Thank you. So yeah, so cellulitis, maybe with 3 months history of cellulitis, of course, there is a huge likelihood that this patient would now have been very septic. Maybe, of course, we would not be discussing the case. But so what about a deep vein thrombosis? That is not something that can be thrown out. Although, again, yes, with the chronic history, it's not something that we encounter very commonly. But So commonly we talk about DVTs of the lower limbs, but it's very possible to have a DVT in an upper limb. So that is one of the differentials that we have. We are talking about something in the vascular territory. So a DVT is a possibility. But then does it explain everything? Of course, when you have congestion and pressure builds up, it can lead to neurological compromise, leading to weakness that we see in this patient. But then, of course, it doesn't explain everything, but that's one of the differentials that we have. Now, the other issue that Joseph is telling us, so of course, we would be very much interested to know about the pulse in this limb. Joseph is telling us that the rest of the exam is normal. So I'm making an assumption that the pulse was palpable on this limb, and it's synchronous with the pulse on the other side.
Yes, it was normal.
So yeah, so if pulse is normal, of course, I had a differential of compartment syndrome. So compartment syndrome, of course, over time you'd lose the pulse. Over time you'd lose the pulse. So maybe compartment syndrome is not not a huge possibility in this patient, although we can keep it low on the list, because maybe it's the patient can have a few of the 6 P's that we talk about, but DVT I think high on the list. So the limb being spastic and then it's clenched, thumb in the palm, it's not warmer, and then it's tender with allodynia, of course, with neurological involvement. So the allodynia is one of the positive symptoms I was talking about, or the paresthesias that we talk about, and that can come with many kinds of neuropathy, so including as a result of compromise. Now, it's tender, so slight touch as well as palpation. And now the other thing that of course raises question in many questions in me, just like it did to Elias, is that this tenderness is starting from the hand and then extending all the way to the shoulder, and it also involves chest muscles in proximity to the shoulder. So if I recall my distant anatomy, I think Elias's anatomy is more up to date than mine. He already talked about the brachial plexus. So another thing that we need to talk about is the arterial supply as well as the venous drainage of the upper limb. So when you talk about the arterial supply, of course, depends on the side, and because my anatomy is very distant, but you know, from the aorta you have some branches, the brachiocephalic on one side, and of course on the other side some branches will originate independently, and then from there you have the axillary artery, or the subclavian artery, and then it goes down, and then you can have your branches. So we are not thinking that this is likely an arterial problem, because we would have had gangrene, and the pulse is palpable, so not likely to be an arterial problem. But then with my limited knowledge, I think there is a possibility that this is a venous issue. So Joseph, can you mute Antimon? Yeah, so with the venous drainage now, the upper limb, of course, you'll start with all your vessels, but at least when we come we have the subclavian vein, and then the subclavian vein will go and drain and drain into the vena cava. So we could be dealing with something obstructing at the level of the subclavian vein or beyond. Now, what could that be? I do not have an answer to that question. So I'm thinking up to this point that most likely we are dealing with something vascular, and the the neurological symptoms that we see a direct consequence of the vascular obstruction, rather than a cause of the symptoms. So, but of course, it could be something else. But that's where we are so far. So, Joseph, I think we are going to the labs. I'm not sure if they will be very helpful, but I think we need labs and we also need imaging. Those can help us make progress.
Yeah, sure. So I think because of time, I'll present the rest of this case. And so the labs were all normal and remarkable. From full body picture ESR, renal, liver functions, urine analysis, RBG, and HIV is negative. Here's the X-rays. I'll go back to them if you need, but just look at them. So she couldn't a- abduct the arm fully. We took the X-ray like this, and we can go back to them later. But of importance, the Doppler ultrasound of the right upper limb was normal. I think at this point you have to give me a diagnosis if you have one.
Okay, so Elias, do you have any thoughts based on those? So the labs are normal. So imaging, Joseph, may be just based on yes. So with these X-rays, Elias, anything that you have based on these extra pieces of information, any thoughts?
Well, my hope was that investigation which were made and the will, I think all the basics lab workups were done, and the way they showed a remarkable sign of wailing, anything abnormal. So I rely on with imaging. So on imaging, maybe the one showing the joint of the yeah. Well, up to now, I have nothing. I have nothing. Maybe back to WJ.
Yeah, you are not alone, my friend. I'm also as much stuck as you are. So with the Doppler that Joseph presented, so Joseph, maybe for these X-rays, I've tried to zoom in and see if there's anything. What was the report like,
They were normal.
Joseph?
Oh, sorry. I'm muted. Sorry, I was muted. So the X-rays were normal.
Okay, so X-ray is normal, and then we are told that Doppler of the upper limbs. So I believe that is both for arterial as well as venous Doppler. They were both normal, right?
Yes. Yes, they are normal.
Okay, so Doppler, because we had, so for venous obstruction of, although of course we also need to remind ourselves of the characteristics or performance of different investigations in the context of different diseases. Of course, Doppler is not Doppler itself also not 100% sensitive or specific, although if we are talking of venous obstruction, for example, at least, even if they didn't see a thrombus, but at least if there was pressure building up on compression of the vessels, they would see some impairment in compressibility of the vessel. So the Dopplers being reported to be normal, of course, they drastically reduce the possibility that we are dealing with a venous obstruction, for example. So the question remains, although yes, it's now, because I personally do not have something better to cling to. I'm still thinking, especially venous obstruction is still a possibility that I'm thinking about, but I have to stretch my mind now and think about other possibilities. So, Joseph, did you say when you were examining the entire limb was swollen?
Yes, compared to the left, this limb was swollen.
This limb was swollen. So the question remains now: where is the swelling? The swelling is the swelling at the level of course, the skin. The skin is not that much. We have swelling of the skin and subcutaneous tissue when there is lymphatic obstruction. And for lymphatic obstruction, of course, Joseph did not tell us whether was there any pitting? I
No,
mean, was
no,
this limb edematous?
no pitching.
Okay, so did it have the famous woody appearance that we know
No,
that is characteristic of lymphedema?
no woody appearance. It's like an inflamed limb. How the inflamed limb is swollen.
Okay, so the limb is not edematous, meaning you are, yeah, I mean you are pressing. There is no pitting.
Mm.
Where you have a lot of fluid collection in the soft tissues, and then it's not woody, something that you see in the lymphatics, but then the limb is swollen.
No.
And you do Doppler is normal. So I think, of course, I would need to order further imaging, especially although I know we have a limitation in resources, but of course this is a patient who needs imaging to examine the soft tissue. So MRI would be the best. In order to tell us what is going on. But then what is going on? So I still entertain these possibilities, although I should say at this point the hopes that it is what is going on are abysmal. So lymphatic obstruction, not very likely based on the characteristics you've told us. Venous obstruction with the Doppler that you presented, although I would need to go back and see, especially for the upper limbs, what is the performance of Doppler. And then I would need to do advanced imaging like an MRI for this patient. But then if it's not that, is this swelling in the soft tissues? If it's in the soft tissues, then what is causing the swelling? We go back to the same questions. Um, cellulitis, I think, not very much entertained for the patient, but and especially also we saw the other labs, they are normal, and the physical exam is normal. So another thing is, could this swelling be at the level of the muscles? We are dealing with the problem with the muscles. Now, what would that be? Because the myopathies that we know commonly do not present this way. So, I mean, could the muscles, maybe it's the muscles that are edematous and it's the muscles that are causing the swelling? I'm not sure about the pain. What would that thing be? So, yeah, I think up to this point, I have more questions than answers, and I do not have a straight diagnosis. So, and for the interest of time, we'll just sit back, listen to you, Joseph, reveal the diagnosis and teach us what transpired.
Yeah. So it was also very difficult for me. Actually, I didn't have the diagnosis. And when you don't have a diagnosis, you tell the patient something. I told her they should go and see a neurologist, thinking maybe you get it right. But I went back and tried to read aloud. Turned out it fits a lot with one diagnosis that I'm going to share with you here. And this is called complex regional pain syndrome. It was my first time hearing about this, and it made sense with the patient presentation. So I called this patient back and explained what is happening and told her about the management. So the definition is complex regional pain syndrome is a spontaneous or evoked regional pain. It doesn't follow any nerve territory, as you're seeing in this patient. If you try to put it in a territory, it doesn't follow. That's why you find yourself struggling, as I did. And so the pain is seemingly disproportionate to any known trauma or other lesion. The epidemiology is like that. Females are more prone to this than males, 2 to 1 to 4 to 1. And inciting events includes the one that Michael was asking about, fracture, sprain, surgery. But 10% of these patients have no inciting events. There are two types. Type 1, which is 90% of these patients, there is no peripheral nerve injury, which was like in this patient. In type 2, there is a peripheral nerve injury. The pathophysiology is unknown. It is thought that maybe there is autoimmunity against autonomic neurons, or there are other theories that didn't even understand. The presentation, there is pain, there can be erythema, swelling, there is sensory changes, like in this patient, it was allodynia, but other things like hyperalgesia, hypoesthesia can be there. There are also motor changes. There can be weakness or tremor. This patient had tremor, myoclonus, dystronic posture, like the hand posture that this patient had. It's like someone with a dystonia. There also can be autonomic dysfunction, skin color change can be there, temperature change, sweating can also be there. Skin changes like increased hair growth or nail growth, contracture, skin atrophy. And initially, in the start of the disease, the limb can be warmer compared to the rest, but as the days progress, it becomes the same temperature as the rest of the limb. So I saw this patient at 3 months. That's why it was normal. Upper limbs are usually more affected than lower limbs. This patient was an upper limb. The diagnosis is just clinical. You just have to listen, and nothing else makes sense. There is no such neuro lesion. If you localize the disease, you're not seeing anywhere because it is not a dermatomal involvement. It is nothing. So it's a clinical diagnosis. Treatment is just physiotherapy, NSAIDs, and gabapentin. But unfortunately, the earlier the diagnosis, the better. If you diagnose this patient early, you start physiotherapy. For example, if someone catched it when it was still at the hand level, it would have been so easier to manage, because I found it so hard. The pain was very much worse to manage. So you take this patient to go to physiotherapy, she cries a lot. And then there are other issues like um, financial issues. She couldn't do much of the physiotherapy. So I lost her in the follow up. I believe she went back home after we explained the disease to the relatives. She went back home. Maybe she will be doing physio from there, but it's so hard. So the importance of also having good diagnostic skills is catching diseases earlier. It's unfortunate she went in. She went in some pretty big hospitals, but these investigations were done, and then there was nothing. She would keep jumping from one hospital to another. Uh, so yeah, that's it. Maybe we can hear from you guys. But one thing I should say is that yeah, I'm so impressed with the the first medical student that we had here today, Elias. There is a difference of 10 years between Elias and David. And David is a teacher, teach students like Elias, but this Elias is pretty good. I think he'll do internal medicine one day. Keep it up, Elias. Very, very nice. You say what you know. That's why we are here. You just have your diagnosis. Everyone knows something from, even from your from your basic science classes. So yeah, from you, David.
Thank you. Thank you.
Yeah, so thank you very much, Joseph. So it's time for reflections, and I should say, so first of all, just like I said, I mean, I think the level of happiness that I have today is over the roof, is beyond the roof, because as much as we couldn't get the diagnosis right, something that we are used to many times, that it's a few times that a case is presented and then we do not get the diagnosis right, but something that I'm very happy about is that we had Elias discuss a case today. I think I should just tell you, Elias, that you are a trailblazer. There are residents who are afraid to discuss. So I think you are an inspiration to all of us, not just to residents, to other medical students, but to specialists like us. That sharing knowledge should be something very intuitive. We should not shy away from sharing what we know, because after all, it's common wisdom that we hear that if you want to learn more, teach. That's how you learn. You learn by teaching. So I'm very much impressed by you, Elias, and I encourage you to keep up the spirit. And of course, just like Joseph said, internal medicine is your place, because this is where you utilize your thinking to the maximum. So I'm looking forward to I'm looking forward to many more discussions alongside you, and you being an integral part of the platform, discussing cases, presenting cases, and sharing your knowledge, because after all, your knowledge base is very advanced, beyond your level. The way you integrate things is very good. So I think this is a good example. We've had struggles with people volunteering to discuss cases. I think you've shown them an example, and I hope we will have many more medical students discussing cases just like you did today. And back to today's case, Joseph, thank you very much for teaching us. Of course, I remember hearing about this term, but I do not think I would have mentioned it in 1,000 years, even if I kept thinking about this case without going and reading. So it's a new thing learned for me. So thank you very much. Elias, if you have any reflections before we welcome some winding up remarks and closing.
Well, thank you for today's presentation, Dr. Joseph. Thank you, Dr. David. Well, I have learned a lot from today's presentation. I have learned a lot from you yourself, for example. And today I've gained exposure because it is my first time. And, you know, I saw the link at my group. So when I saw the link, then I said, why not join? Because I'm just staying here. I'll just use my time watching maybe a documentary or a movie. But why not use my time to go and listen what is presented here? Because I had a curiosity. What is there? Why they have shared? Why have they shared this link? And what motivated me to come here is the link was set in case presentation. So I had something in mind. What are they going to present? Because I had such particular session in our association, because we medical students, we have an association, so we have the session for case reports. So when I saw that and it came to my mind, maybe it is similar with that one. So I had to come because I also I'm interested in writing case reports, and the way you presented today this case, it has made a lot. It has contributed something into my knowledge. So even after here, I will go and read this complex region pain syndrome more. Why is it? And of course, this will be at my frontal region. When I meet such particular patients, I also use this as a differential diagnosis. And I would love to have other sessions like this more, because this is a session which I would advise other medical students to come and learn and know how to make a diagnosis, because we are still learning, and this is part of the learning, because getting different exposures makes us more perfect, because our teachers teaches us, but also we have to get another input from other people around the world. And today I'm happy to get this input from you guys. And I would love to have another session. And I would love to connect with you if there is any WhatsApp group which you communicate, which you share this which you share these links for presentation. I would love to get this in order to share with my fellow students who might benefit with this program. Thank you.
Oh, thank you very much, Elias. That's very impressive. And yes, this is so we meet here every weekend. So every Sunday at 8 p.m. So just reach out. Um, if you I'll share my email. I hope I'll find a way. So if you, I'm not sure if there is a way someone can see an email on this, but I would love to connect so that we share the link every weekend, and of course encourage as many other people as you can to join, because this is free, and we this is our little way of sharing the knowledge we have with everyone, and to make sure that we inspire each other to learn more for the betterment of our patients. So thank you very much. I see your email here, so we'll reach out and keep sharing the links so we can keep learning. So I think we are way beyond time. I'm not sure if there's anyone with any burning issues before we close.
Yeah, I think we should close.
Yeah, I do not see any hands up. Joseph, do you have anything?
No, I'll see you next Sunday.
Okay, see you everyone next Sunday. Have a good night.
Good night.